Hello everybody, today we have lecture about rectus sheath hematoma.
Doctor. Can start now.
Rectus sheath hematoma is an uncommon and often clinically misdiagnosed cause of abdominal pain. It is the result of bleeding into the rectus sheath from damage to the superior or inferior epigastric arteries or their branches, or from a direct tear of the rectus muscle. Emergency physicians and other clinicians should be familiar with rectus sheath hematoma, because it can mimic almost any abdominal condition. While usually a self-limiting entity, rectus sheath hematoma can cause hypovolemic shock following sufficient expansion, with associated mortality. Rectus sheath hematoma is an ancient disorder, first being accurately described by Hippocrates and mentioned by Galen. The first reported case in the United States was by Richardson in 185.
Doctor. What are the anatomic features of rectus sheath muscle?
The rectus abdominis muscles are two parallel vertically aligned muscles. The rectus abdominis muscles arise from the superior ramus of the pubis and insert into the ventral aspect of the fifth, sixth, and seventh costal cartilages and the xiphoid process. The rectus muscles are separated in the midline by the linea alba. The lateral boundary of the rectus sheath is the linea semilunaris. The arcuate line is located about 5 centimeters below the umbilicus and functionally separates the rectus sheath into superior and inferior portions. Above the arcuate line, the aponeuroses of the external oblique, the internal oblique, and the transversalis muscles invest the rectus muscle. 3 to 4 transverse tendinous inscriptions attach the rectus muscle to the enveloping fascia, usually above the arcuate line. The tendinous inscriptions form the typical segmental pattern of the rectus abdominis muscle. Below the arcuate line, the aponeuroses remain intact anteriorly, but only the weak transversalis fascia and peritoneum separate the muscle mass from the abdominal viscera posteriorly. The inferior retrorectus space communicates with the prevesicular space of Retzius. This communication creates a natural dissection plane between the posterior rectus sheath and the bladder. The arterial supply to the rectus sheath is derived from the superior and inferior epigastric arteries. The inferior epigastric artery originates from the external iliac artery. It rises from the inguinal ligament to enter the posterior rectus sheath inferiorly. The inferior epigastric artery then ascends loosely between the rectus abdominis muscle and the posterior rectus sheath. During contractions of the rectus abdominis muscle, the length of the muscle changes, and the artery must glide with the muscle to avoid tearing. The combination of the loose attachment of the inferior epigastric artery with the stabilization of its perforating branches fixed to the muscle belly makes the artery prone to shearing stresses at branching sites during strong muscular contraction. The superior epigastric artery originates from the external thoracic artery. The superior epigastric artery enters the sheath from behind the seventh costal cartilage and descends between the rectus abdominis muscle and the posterior rectus sheath. The superior and inferior epigastric arteries form rich anastomoses near the level of the umbilicus. The anastomoses are microscopic, helping to diminish the likelihood of trauma to the vessels during muscular contraction.
Doctor. What about the pathophysiology of rectus sheath hematoma?
Rectus sheath hematomas, RSHS, are generally caused either by rupture of one of the epigastric arteries or by a muscular tear with shearing of a small vessel. The immediate cause of the rupture may be external trauma to the abdominal wall, iatrogenic trauma from surgery, or excessively vigorous contractions of the rectus muscle. These vigorous contractions are often seen in strenuous exercise or repeated Valsalva maneuvers with severe coughing, vomiting, or straining at the stool. Because the arteries supply the recti posteriorly, most hematomas are posterior to the muscle, making diagnosis by means of palpation more difficult. Tesk's 1946 case series of 100 patients with rectus sheath hematoma showed 60% to be on the right side and more than 80% to be in the lower quadrants. Right-sided hematomas are presumably more common because more people are right-handed and, thus, are more prone to right-sided strain of the rectus muscle during strenuous activity. The lower quadrants are more frequently involved because of the long vascular branches that are present and because muscle excursion during contraction with the absence of the tendinous inscriptions is greater. Hematomas above the arcuate line are generally caused by damage to the superior epigastric artery or its perforating branches. Patients usually present with unilateral, small, spindle-shaped masses because these hematomas are isolated by the rectus sheath and the tendinous inscriptions, causing tamponade of the bleeding. Hematomas below the arcuate line are caused by damage to the inferior epigastric artery or its perforating branches. They protrude posteriorly and appear spherical, because the rectus abdominis muscle is only supported posteriorly by the transversalis fascia and the parietal peritoneum. Below the arcuate line, hematomas bleed more and may dissect extensively because no posterior sheath wall or tendinous inscriptions are present to tamponade the bleeding. Rectus sheath hematomas below the arcuate line are more likely to cross the midline and become bilobare. Hematomas near the umbilicus are rare. They are small when they do occur because the microscopic anastomosis of the superior and inferior epigastric arteries near the umbilicus do not allow for significant bleeding. Hematomas near the peritoneum can result in peritoneal irritation, subsequent abdominal rigidity, and gastrointestinal symptoms. Dissection of the hematoma inferiorly into the prevesicular space of Retzius can masquerade as a pelvic tumor or irritate the bladder, resulting in urinary complications. In 1996, Berna et al. Used the appearance of rectus sheath hematomas on CT scans to differentiate 3 levels of severity with disposition and therapeutic implications, as follows. Type I, the hematoma is intramuscular, and an increase in the size of the muscle is observed, with an ovoid or fusiform aspect and hyperdense foci or a diffusely increased density. The hematoma is unilateral and does not dissect along the fascial planes. The patient presents with mild to moderate abdominal pain and typically does not require hospitalization. Type I hematomas resolve by themselves within 1 month. Type 2. The hematoma is intramuscular, mimicking type 1, but with blood between the muscle and the transversalis fascia. It may be unilateral, but is usually bilateral, and no blood is observed occupying the prevesical space. A fall in hematocrit may be observed. A patient may require hospitalization for close observation, but most do not require transfusions, and most are discharged to home within 3 days. Type 2 hematomas usually resolve within 2-4 months. Type 3. The hematoma may or may not affect the muscle, and blood is observed between the transversalis fascia and the muscle, in the peritoneum, and in the prevesical space. A hematocrit effect can be observed, and, on occasion, hemoperitoneum is produced. These patients are often taking anticoagulation medications and require hospitalization. They often require transfusion and are discharged after 1 week. Only rarely will they develop hemodynamic instability that cannot be controlled with fresh frozen plasma and fluid resuscitation. These unstable patients may require surgical intervention. Type 3 hematomas usually require more than 3 months to resolve. After resolution, rectus sheath hematomas usually do not recur and typically do not cause long-term sequelae.
Doctor, what about etiology of rectus sheath hematoma?
Several risk factors of rectus sheath hematoma can be obtained in the history. In most cases of rectus sheath hematoma, one or more precipitating factors can be found. Reports of spontaneous rectus sheath hematoma exist, but more likely, in these cases, the precipitating factor was not appreciated. Anticoagulation is the most frequent predisposing factor, and severe coughing is the most important inciting factor. Anticoagulation rectus sheath hematoma is a well-recognized complication of anticoagulant therapy. Anticoagulation can be a predisposing factor, or it can directly cause rectus sheath hematoma by accidental intramuscular injection of LMWHs. Heparin-induced immune microangiopathy has been proposed as a mechanism of the pathogenetic process. Case reports exist of rectus sheath hematoma resulting from use of apixaban or enoxaparin, and a 2020 case report discussed fondaparinum-associated rectus sheath hematoma in a middle-aged male with severe abdominal pain following a violent cough due to a respiratory infection. Rectus sheath hematoma secondary to anticoagulation may have greater morbidity and mortality because of increased hemorrhage volume. Even when coagulation factors are within the therapeutic range, a substantial risk of hemorrhage still exists. Coughing. Rectus sheath hematoma can occur after bouts of severe coughing, explaining its association with asthma, tuberculosis, influenza, pertussis, and other respiratory infections. Pregnancy. Rectus sheath hematoma is associated with pregnancy in the gravid state, during labor, and in the early postpartum period. Previous abdominal surgery. Abdominal operations predispose to rectus sheath hematoma because surgical scars redirect the shearing forces on muscle contraction, placing more stress on the epigastric vessels. Recent abdominal surgery. Excessive retraction or inadequate hemostasis can cause rectus sheath hematoma that may become evident up to 4 weeks after the procedure. Chronic kidney disease. In a study by Sheath et al. Involving 115 hospitalized patients with a confirmed diagnosis of rectus sheath hematoma, 58.3% of them had chronic kidney disease of stage 3 or higher. Steroid or immunosuppressive therapy. In study by Sheath et al., 41.7% of the patients were undergoing steroid/immunosuppressive treatment. External trauma. The nature of the trauma can be trivial. Tight contraction of the recti in anticipation of a blow predisposes to rectus sheath hematoma formation. Vigorous uncoordinated rectus muscle contraction. Rectus sheath hematoma has been observed in a healthy man leaping over a ditch and in a woman rising from a chair to adjust a curtain rod. In a similar manner, sports activities and exercises, such as golf, tennis, skiing, and weightlifting, have caused rectus sheath hematoma. Activities with significant Valsalva effort, such as coughing, sneezing, straining from constipation, urination, and sexual intercourse, have been implicated in rectus sheath hematoma. General medical conditions. General medical conditions that predispose to rectus sheath hematoma can be categorized as those causing damage to blood vessels, those causing failure of coagulation, or as anomalous conditions, such as endometriosis in the rectus sheath. Vascular conditions of hypertension, arteriosclerosis, and collagen vascular disease are associated with rectus sheath hematoma. Disorders of coagulation associated with RSH include leukemia, myeloproliferative disorders, hemophilia, and blood dyscrasias. Unusual case reports have also described rectus sheath hematoma related to acupuncture and follicle aspiration for in vitro fertilization. Minor surgical procedures such as diagnostic or therapeutic paracentesis have also been shown to cause rectus sheath hematoma. In addition to LMWH injections, rectus sheath hematoma has also been seen in any abdominal wall medication injections, for example, insulin. These unusual causes underscore the importance in obtaining a thorough history from the patient.
Doctor, what about the epidemiology of rectus sheath hematoma?
Regarding international data, rectus sheath hematoma is an uncommon, but not rare, cause of abdominal pain. In 1999, Klingler et al. Found an incidence of 1.8% among 12 of 57 patients admitted to the hospital with abdominal pain and undergoing ultrasonography for diagnosis. Anticoagulation is a well-known risk factor. The incidence is thought to be on the rise, with the increased use of oral anticoagulation drugs and low molecular weight heparines (LMWH). Regarding race, sex, and age-related demographics, rectus sheath hematoma is reported to occur less often in black persons, with only 4% of rectus sheath hematomas occurring in people of this race. Whether this low rate is physiologic, a result of sample reporting, or diagnostic bias is unknown. Rectus sheath hematoma is 2-3 times more common in females than in males. The higher incidence in women has been attributed to their decreased muscle mass. The sex distribution seems to be equal in younger age groups, although the predisposing factors differ. Pregnancy is a risk factor in younger females, whereas males more commonly develop rectus sheath hematoma after trauma or muscular exertion. In a 1946 review of 100 cases, Tesk reported the occurrence of rectus sheath hematoma in patients aged 4-83 years, with an average age of 47 years. The peak age of incidence is in the 5th decade of life. Incidence increases with age as the protection provided by the rectus sheath becomes compromised by decreased muscle mass. The effects of arteriosclerosis and hypertension also render vessels more susceptible to injury.
Doctor, what about the prognosis of rectus sheath hematoma?
Although usually a benign self-limiting condition, rectus sheath hematoma (RSH) may be fatal. Mortality figures are prone to error because of the uncommon incidence of rectus sheath hematoma and the paucity of recent mortality data. Overall, the mortality rate is reported to be 4%. The mortality rate for iatrogenic rectus sheath hematoma is reported to be 18%, whereas the mortality rate for patients with rectus sheath hematoma who are undergoing anticoagulation therapy is reported to be 25%. Pregnant patients have a reported mortality rate of 13%, with a 50% mortality rate for the fetus. These mortality rates were reported prior to the widespread use of ultrasonography and kinetic scanning to aid in the early diagnosis of rectus sheath hematoma. Early diagnosis likely reduces the mortality rate, but no studies to date are available to demonstrate this. The high mortality rate in patients undergoing anticoagulant therapy is related to the larger hematomas as well as the increased age and significant comorbidities of these patients. The morbidity of rectus sheath hematoma is primarily the result of incorrect diagnosis leading to unnecessary exploratory laparotomy, delay in cessation of anticoagulant therapy, or delay in fluid resuscitation and blood transfusion. As with other abdominal pathology in the older patient, Extra care should be devoted to an expedient and accurate diagnosis in elderly patients. Elderly patients are more likely than younger patients to require aggressive resuscitation, anticoagulation reversal, and admission. For these reasons, elderly patients also experience an increased mortality rate. There are also case reports of rectus sheath hematoma causing bladder perforation, ureteric obstruction, bladder outlet obstruction, obstructive uropathy, abdominal compartment syndrome.
Doctor, what is the clinical picture of rectus sheath hematoma?
Common historical features of rectus sheath hematoma (RSH) include acute abdominal pain, fever, nausea, and vomiting. The nonspecific nature of these symptoms combined with the low incidence of the disorder lead to difficulty in considering this diagnosis. Rectus sheath hematoma should be included in the differential diagnosis of every patient who presents with abdominal pain. Specific symptoms. Constitutional. Fever and chills are common symptoms in rectus sheath hematoma. Symptoms of hypovolemic shock with weakness, confusion, pallor, and diaphoresis can develop in patients with a large rectus sheath hematoma. Abdominal pain. The most common presenting symptom is acute abdominal pain. The onset of pain may be sudden, but more often, it develops over a period of several hours. The pain is typically sharp and severe, with an associated palpable abdominal mass. Pain is usually worse with movement and is often unilateral. Constant pain with episodic abdominal cramping is also a frequent symptom. In atypical cases, the pain may develop insidiously, making the abdominal mass difficult to differentiate from an abdominal wall neoplasm. Gastrointestinal or urologic. Anorexia, nausea, vomiting, diarrhea, constipation, tenesmus, and bladder irritability are all compatible with the diagnosis of rectus sheath hematoma. The severity of symptoms is related to the degree of peritoneal irritation. Precipitating factors. The clinician needs to have rectus sheath hematoma in the differential, or the diagnosis will be easily overlooked. A careful history should include directed questions regarding surgical procedures, occult blunt trauma, coughing, sneezing, constipation, straining at the stool, or exercise. In patients with certain medical problems, questions about recent asthma exacerbations, bronchitis, or upper respiratory tract infections may prove helpful. Rectus sheath hematoma must always be considered in abdominal pain patients on anticoagulants. Physical examination. Vital signs. A low-grade fever is common in rectus sheath hematoma. The hematoma can be large enough to compromise intravascular volume, with resultant signs of hypovolemic shock including hypotension, tachycardia, and tachypnea. Abdominal examination. Typically, the abdominal examination reveals a palpable, painful, firm, non-pulsatile abdominal mass corresponding to the rectus sheath. The mass may be bilibar with a central groove. The mass does not move with respiration. Because the hematoma is deep to the subcutaneous tissue and rectus muscles, the mass is not always palpable, particularly in obese patients. In 2000, Berna et al.'s case series reported a palpable mass detected in 8 of 12 patients. Hyperesthesia of the overlying skin is not uncommon. Bowel sounds may be absent. Signs of local peritoneal irritation with rebound tenderness and involuntary guarding may be present. This finding is most often seen in infraumbilical hematomas due to the thin transverse fasciculus serving as the only barrier between a hematoma and the peritoneum. Rarely, a hematoma may cause extraperitoneal compression of the abdominal cavity and cause abdominal compartment syndrome, or even rupture into the peritoneum, causing a chemical peritonitis. The Fothergill sign is useful in determining whether an abdominal mass is part of the abdominal wall or whether it is in the abdomen. It is elicited by voluntary contraction of the rectus muscles by the patient lifting either his or her head or legs while in the supine position. With this action, rectus sheath hematomas become fixed, more painful, and more tender, while intra-abdominal masses become less distinct and less tender. The Fothergill sign may be inconclusive in patients who are obese or pregnant. As described by Fothergill in 1926, this patient complains of pain and the medical man finds the swelling. The trouble is that he seldom knows how long the swelling has been present. The main point is the recognition that these swellings are part and parcel of the abdominal wall. This is generally made by noting that they can still be felt when the recti are intact, and that they become fixed as the muscles contract. The Carnot sign is an additional test to assist in differentiating between abdominal wall and intra-abdominal pathology. It is performed by having the patient lie supine and tensing the abdominal musculature by raising either the head or the shoulder off the table. A positive sign is elicited if abdominal tenderness is increased or unchanged while tensing the abdomen. This indicates an abdominal wall process. A negative sign, or decreased abdominal tenderness while tensing the abdomen, suggests intra-abdominal pathology. Previous studies have demonstrated this sign to be fairly sensitive, but not specific for abdominal wall pathology. The Cullen sign of periumbilical ecchymosis is associated with retroperitoneal or abdominal wall hemorrhage. In rectus sheath hematoma, ecchymosis appears after 2-5 days. The ecchymosis uncommonly extends into the flanks. The Gray-Turner sign is another manifestation of retroperitoneal hemorrhage. This finding of flank ecchymosis was initially described in hemorrhagic pancreatitis, and along with the Cullen sign, it is not specific for retroperitoneal or abdominal wall hemorrhage. Pelvic examination. The pelvic examination may reveal a mass anterior to the vagina and above the pubis. The pelvic examination may be misleading, particularly in those cases that demonstrate unilateral adnexal tenderness and mass.
Doctor, what about rectus sheath hematoma differential diagnoses?
Abdominal pain in elderly persons. Abdominal trauma, blunt. Appendicitis. Cholecystitis and biliary colic. Urinary tract infection (UTI) and cystitis, bladder infection in females. Diverticulitis. Emergent management of abruptio placentae. Emergent management of ectopic pregnancy. Emergent management of pancreatitis. Emergent treatment of gastroenteritis. Gallstones, cholelithiasis. Hemorrhagic shock in emergency medicine. Hernias. Hypovolemic shock. Intussusception. Large bowel obstruction. Mesenteric ischemia imaging. Ovarian cysts. Ovarian torsion. Pediatric appendicitis. Pediatric gastroenteritis in emergency medicine. Peptic ulcer disease. Pregnancy trauma. Small bowel obstruction. Urinary tract obstruction management in the emergency department. Urinary tract infection (UTI) in males. Urinary tract infections in pregnancy.
Doctor, what about rectus sheath hematoma workup?
Regarding laboratory studies. Complete blood cell count. The hematocrit may be normal for small rectus sheath hematomas or significantly depressed with a large hematoma. Serial blood counts may be useful in an expanding hematoma to assess the need for blood transfusion or more aggressive therapeutic measures. The reported white blood cell count ranges from 6.6x103 to 29x103. As in other acute abdominal disorders, a normal white blood cell count does not rule out rectus sheath hematoma. Coagulation factors. Although coagulation factors are not helpful for patients on heparin, they are useful for patients on oral anticoagulation drugs or for those with a pathologic failure of coagulation. Rectus sheath hematomas are more likely with supratherapeutic anticoagulation, but they can occur in the therapeutic range. Patients undergoing reversal of anticoagulation benefit from serial coagulation factors to assess the response to therapy. Arterial or venous blood gas. Knowledge of the base deficit from a blood gas level is useful in patients with hypovolemic shock due to rectus sheath hematoma. Serial blood gas levels can be used to guide fluid resuscitation. Regarding imaging studies, ultrasonography can be used as a first-line diagnostic test for rectus sheath hematoma, or it can be used to monitor the evolution of a known hematoma. Ultrasonography provides rapid, accurate information about the size, the location, and the physical characteristics of the mass. It is safe and well tolerated. It does not expose the patient to radiation or intravenous contrast material. The typical ultrasonographic findings are sufficient to establish the diagnosis. Expected findings. Rectus sheath hematomas are described as spindle-shaped on sagittal sections and as ovoid on coronal sections. Usually, the mass is snolucent, although it may also be heterogeneous, depending on the combined presence of clot and fresh blood. Effectiveness. Ultrasonography has been reported to have a sensitivity of 85–96% in depicting rectus sheath hematoma. However, when it is unsuccessful, it often fails spectacularly, causing undue delay in treatment or unnecessary laparotomy. Zinnia's case series of 4 patients in 1988 noted that findings from ultrasonography were misleading in 2 of them. In those 2 patients, the ultrasonographic report describes the pathology as occurring within the peritoneal cavity, prompting unnecessary surgical intervention. Role of ultrasonography. Ultrasonography should be used as a first-line diagnostic test in pediatric patients, pregnant patients, or perhaps in patients with renal insufficiency. However, in other patients, its primary role may be to follow hematomas to maturation and resolution after definitive diagnosis by CT scanning. In patients where the clinician has a moderate to high suspicion for rectus sheath hematoma, ultrasonography serves as a viable screening test. Therefore, even if the sonogram demonstrates a mass that is difficult to characterize as intraperitoneal or extraperitoneal, the clinician's pretest probability can help guide therapy. Caution should always be exercised with patients in whom infection or diagnostic uncertainty exists. Regarding CT scanning, CT may be used as a first-line diagnostic procedure in the evaluation for rectus sheath hematoma, or it may follow non-diagnostic ultrasonographic findings. CT permits a precise determination of the location, the size, and the extension of the hematoma. Information is also obtained about the rectus abdominis muscle and the perimuscular tissue. CT may be more appropriate than ultrasonography as a first-line test, because it simultaneously aids in the diagnosis of rectus sheath hematoma and rules out other abdominal pathology. Expected findings. Characteristic findings of acute rectus sheath hematoma on CT include a hyperdense mass posterior to the rectus abdominis muscle with ipsilateral and interolateral muscular enlargement. Chronic rectus sheath hematoma may be isodense or hypodense relative to the surrounding muscle. Above the arcuate line, rectus sheath hematomas have a spindle shape, while those below the arcuate line are typically spherical. Effectiveness. CT scanning is 100% sensitive and 100% specific in acute rectus sheath hematoma of less than 5 days duration. After 5 days, MRI may be required to differentiate hematomas from tumors of the abdominal wall. Types of rectus sheath hematoma on CT scanning. In 1996, Berna used the appearance of rectus sheath hematomas on CT scans to differentiate 3 levels of severity with disposition and therapeutic implications. Type I, the hematoma is intramuscular, and an increase in the size of the muscle is observed, with an ovoid or fusiform aspect and hyperdense foci or a diffusely increased density. The hematoma is unilateral and does not dissect along the fascial planes. Type 2. The hematoma is intramuscular, mimicking type 1, but with blood between the muscle and the transversalis fascia. It may be unilateral or bilateral, and no blood is observed occupying the prevesical space. A fall in hematocrit may be observed. Type 3. The hematoma may or may not affect the muscle, and blood is observed between the transversalis fascia and the muscle, in the peritoneum, and in the prevesical space. A hematocrit effect can be observed, and on occasion, hemoperitoneum is produced. Role of CT is the diagnostic test of choice for rectus sheath hematoma and is superior to ultrasonography in sensitivity and specificity. Patients who are pediatric, pregnant, or have renal insufficiency may benefit from ultrasonography as a first-line test to avoid radiation and intravenous contrast material. In patients with renal insufficiency, a non-contrast CT scan can be used and will still show the typical findings of rectus sheath hematoma, although the ability to find active extravasation or to rule out other abdominal pathology is limited. Regarding MRI is useful in differentiating chronic rectus sheath hematoma from other interior abdominal wall masses when CT findings are not specific. Chronic rectus sheath hematoma is demonstrated as high signal intensity on both T1- and T2 weighted images up to 10 months following the onset of the hematoma. In acute rectus sheath hematoma of less than 48 hours duration, the MRI of rectus sheath hematoma does not reveal high signal intensity and is not useful in the diagnosis. Many clinicians will be limited by the availability of MRI in their practices, particularly when other types of imaging studies are readily available. Regarding radiography, plain anteroposterior and erect radiography of the abdomen. Plain P radiographs are not useful in diagnosing rectus sheath hematoma, but they may help in ruling out other diagnostic possibilities if no free air, obstructive gas pattern, sentinel loop, appendicolith, or other findings are noted. Lateral decubitus radiography. Lateral decubitus radiography is only of historical interest in diagnosing rectus sheath hematoma. In 1967, Herzen described a rectus sheath hematoma on a lateral decubitus radiograph as a placenta-shaped or ovoid spindle-shaped mass in the anterior abdominal wall or as a widening of the rectus sheath. Regarding scintigraphy, a solitary case report by Mansane and Davis in 1990 describes the use of this diagnostic modality in rectus sheath hematoma. Following positive evaluation by CT scanning of a large mass in the anterior abdominal wall, scintigraphy with technetium-99 tagged red blood cells depicted several sites of bleeding corresponding to previous insulin injection sites. This bleeding was not observed with angiography. The inferior epigastric artery was embolized with gel foam despite an absence of bleeding on angiography with subsequent hematocrit stabilization. Therefore, Scintigraphy can be used after a diagnosis of rectus sheath hematoma by CT to show active extravasation not detectable by angiography. Needle aspiration of rectus sheath hematoma has occasionally been advocated to differentiate rectus sheath hematoma from an abscess and to decrease the duration of symptoms by the removal of the irritating mass. However, most sources consider needle aspiration unwise because of the risk of bacterial contamination and the possibility of bowel perforation if the mass is a hernia sac instead of a hematoma. Also, aspiration of clotted blood is difficult and likely to be unsuccessful. Some sources recommend needle aspiration under ultrasonographic guidance, although this technique still carries the risk of bacterial contamination. One case of hematoma recurrence has been reported following needle aspiration.
Doctor, what about rectus sheath hematoma treatment and management?
Once rectus sheath hematoma is diagnosed, the patient's clinical condition determines appropriate treatment and disposition. Treatment may be either conservative or invasive. Conservative treatment is appropriate for patients who are hemodynamically stable and have small non-expanding hematomas in which symptoms are mild and the diagnosis is certain. Conservative treatment of rectus sheath hematoma includes rest, analgesics, hematoma compression, ice packs, treatment of predisposing conditions, and if necessary, more aggressive therapies of intravenous fluid resuscitation, reversal of anticoagulation, and transfusion. Care must be taken in applying a conservative approach, because even a relatively small hematoma has been reported to cause hypotension and death in a patient who is debilitated. Regarding anticoagulation reversal, patients who are undergoing invasive procedures and those with hemodynamic instability, expanding hematomas, or symptomatic anemia should be considered for anticoagulation reversal. For patients taking oral anticoagulation, reversal can be achieved with phytonadione plus fresh frozen plasma. The patient's clinical condition determins the aggressiveness of anticoagulation reversal. Intravenous phytonadione can be administered at a dose of 1-10 mg. Intravenous phytonadione is associated with rare, but well-documented cases of anaphylactoid reactions. Thus, it must be administered with care at a rate no greater than 1 mg/min, with frequent every 15 min, 30 min, and 1h vital sign measurements. A patient given a dose of 10 mg of intravenous phytonadione may be refractory to Coumadin for several weeks, making 2.5 mg or 5 mg a better dose in all but the most severe RSHS. Subcutaneous phytonadione is associated with an unpredictable therapeutic response and is not recommended. Oral phytonadione has a time to onset that is too slow for a patient who is actively bleeding. Subcutaneous phytonadione is associated with an unpredictable therapeutic response and is not recommended. Oral phytonadione has a time to onset that is too slow for a patient who is actively bleeding. FFP is administered in a volume of 15 ml/kg and provides coagulation factors for as long as 8 hours. FFP may have to be administered with diuretics if volume overload is a concern. Patients on heparin can have coagulation reversed by protamine at a dose of 1 mg per 100 U of heparin. Heparin has a half-life of 60 minutes. A dose of protamine reverses all of the heparin administered in the past hour, 1/2 of the heparin of the previous hour, and 1/4 of the heparin given 2 hours previously, assuming that no recent bolus has been administered. Patients on heparin can have their anticoagulation partially reversed by protamine, although refractory heparinoid fractions are present. Regarding transfusion, the decision to transfuse is made depending on the patient's need for fluid resuscitation, the presence of comorbid conditions, such as active coronary ischemia, the degree of anemia, and the need for an operative procedure for control of bleeding. In 1988, Zania reported the transfusion of blood in 4 of 8 patients in a case series, although none of the patients were hemodynamically unstable. In Berna's case series of 12 anticoagulated patients in 2000, all 5 patients with type 3 hematomas required transfusion and had alterations in hemodynamic variables. Transfusion requirements are generally 2-6 units of packed red blood cells. 2 main modalities exist for invasive control of active bleeding in rectus sheath hematoma. 1. Therapeutic angiography with embolization of the bleeding vessel, and 2. Operative therapy with clot evacuation, ligation of bleeding vessels, and closed suction drainage. Invasive treatment should be considered in patients with enlarging hematomas, hemodynamic instability unresponsive to fluid resuscitation, peritoneal signs, pain not well controlled with analgesics, and persistent gastrointestinal or urinary symptoms. Patients with significant comorbidities may not be candidates for invasive therapy. Regarding arterial embolization, in 1980, Levy first describes the transcatheter Gelfoam embolization technique in the treatment of rectus sheath hematoma. This invasive therapy can produce hemostasis, reduce the size of the hematoma, decrease the need for blood product transfusion, and prevent rupture into the abdomen. Embolization with thrombine, Gelfoam, or coil is an alternative to surgery for conditions not responding to conservative management. More recently, a 2017 case report described the use of Squat peri-liquid embolic device to urgently embolize the right epigastric artery in an elderly patient with spontaneous, non-traumatic hematoma of the rectal sheath. The artery was completely embolized with no active bleeding or other complications. Surgical treatment includes evacuation of the hematoma, ligation of bleeding vessels, repair of the rectus sheath, drainage when indicated, and closure of the abdominal wall. Recurrences following surgical therapy have not been reported. The decision to admit a patient with rectus sheath hematoma depends on the clinical data regarding hemodynamic status and comorbid conditions as well as the size of the hematoma. Patients on anticoagulation therapy should be admitted to ensure that the hematoma is not expanding and to plan restarting anticoagulation as appropriate. In general, patients with type 1 hematomas do not require hospitalization. Patients with type 2 and type 3 hematomas usually do require hospitalization. Patients with type 2 hematomas can be admitted to the floor during the first 24-48 hours to evaluate evolution of the hematoma. Patients with type 3 hematomas often present with hemodynamic instability requiring fluid resuscitation and blood transfusion that is best managed in the intensive care unit setting. Post-discharge care includes rest, analgesics, hematoma compression, ice packs, and treatment of predisposing conditions. Type I hematomas resolve after approximately 1 month. Type 2 hematomas require 2-4 months, and type 3 hematomas require more than 3 months and as long as a year for complete resolution.
Thanks Dr. Dratef for excellent lecture.
Thanks for watching our video and hope to see you again in next videos. But please don't forget to like and share our videos and subscribe to our YouTube channel No One Doctor. With my best wishes. Dr. Dratef.